Of cause-specific mortality, that is the maternal mortality. We all know we have reduced maternal mortality and we can be extremely proud of it, to talk about it anywhere in the world. But if you, and also the communicable diseases, vaccine-preventable diseases, we have brought down so much better than even Malaysia and Thailand, and not as good as Australia, but we have brought down as much as we can. But we cannot relax because our NCD burden has increased and our injuries have increased. Our injury-related deaths are too high for us, for this kind of developed country. And Malaysia, Thailand, and Sri Lanka, for NCDs, we are comparable. But for injuries, we are an outlier in the wrong direction. And I'll spend a bit more time on the transition which Professor Athanayake talked of. We are going through this transition of communicable diseases to non-communicable disease. It's interesting if you look at this slide, the change we have seen with development and over time. And infectious diseases have come down, but look at the circulatory diseases. Circulatory diseases have gone up so much in these last 50 years, and the injuries. And this is why our mortality rates are showing this difference now. And the demographic transition. So what is it in this demographic transition that makes us talk about it? This is a 2007 slide, but in 2011, the widest point is at the working age population. And we will have this wide point going on for a few more years, till about 2016, 2020. And after that, more people will be in the dependency ages, that is the older people and the younger group. And the time that you have the most amount of people in the working time, and that is the demographic dividend, and that is the time we need to have economic development. And we are having that now. If we have that growth and we have this group of people who are in their productive ages and healthy, that is our dividend, and that is how we can have that economic development boost that all of us are waiting for. But we cannot relax on everything that I talked of, because we also have a nutrition problem, which we should not be having, because we are now middle income and we are developed compared to so many of our countries in the region. We still have 17% of stunting, children below 5 years. They are stunted with high percentages, and a good number are still born as low birth weight babies. 18% is again very high for our income status. And you also now see the trend of obesity, and children, about 20% of children are reporting obesity, and that these are also not good indicators. In this slide, I'm trying to just highlight that, our health system, we have a free health system that is extremely well laid out and is accessible to anybody. And that is the success of our indicators. But if you also we need to be conscious that is our health system performing as well as it has been performing? And if not, should we do any corrections to our system? And this slide actually gives us a small indication that we should now, as planners, start thinking whether there is some other issues that we need to sort out. The slide on impoverishment, slide on the far end, actually shows the out-of-pocket expenses that people use. That is, if somebody gets ill, people use a particular percentage of their money, private money, to manage the health. We have a free health service, but traditionally our out-of-pocket expense is about 53%. Out of that, about 46% people actually use their own money when they are ill to buy for drugs or lab sector or other things. And this trend, if people use 40% of their income or more, they are really that means the health burden is too much on their income. And that percentage is increasing. 1994 levels show 1.7% of people were like that, but in the 2004 levels, we are just below Bangladesh and India at 2.1%. So these are small indicators that we need to look at now so that we could prevent further deterioration. And the slide on this side is on catastrophic levels. That means people really go back to poverty. I said our poverty indicators improved, 9% poverty. But if health and out-of-pocket expenses increase, they can actually go back to being poor. And that percentage also has increased in Sri Lanka. So few minutes on the future prospects. So I haven't said that Sri Lanka is all fine. Health has been good. We have achieved a lot, but we have much more to achieve. And the total health expenditures will increase. And we think with development, private sector investments will increase, and the government health spending will increase. As Professor Attanayake mentioned, government health spending can be more. We don't have as comparably as other countries of our income yet. And with the end of the war also, I think that investment will also go to health, and that spending will increase. And we need to also look at the out-of-pocket expenses and see whether there's a risk protection that can be allowed, or increase government spending so that people reduce their out-of-pocket expenditures. When I say risk protection, that means people actually, like in a health insurance scheme where people actually put in money before they are ill. But if the government if the government doesn't want to do that, they can increase government health spending and reduce the cost of money that they have to spend when they are ill. Then partnerships with the private health sector. This is also the new trend, and there's scope there where we actually haven't done much to allow the people who have the resources to seek care from places that they can afford to pay. If we look at Sri Lanka, Western Province and Kandy and Galle has some private sector facilities, but overall Central has, North Central, North East, these places actually don't have enough private for people who want to go to even. So we need to maintain our health status achievements for mother and child and communicable disease. If we relax on that, we will not be able to maintain this, and that is so very important for us to maintain that. While maintaining, we need to look at how to sort out these other issues that are now coming up as issues for us. And the chronic NCDs are such issue. One such issue, the circulatory diseases, hypertension, strokes, and all other diabetes mellitus, all these diseases. So we need to think, can we move this population and delay the onset of them getting ill by 1 year, 2 years, or 3 years? And if we do that, we reduce the burden of that population on the hospital. And that is the most cost-effective way forward for us on the longer term. But this doesn't mean that we should not diagnose the ones who already have the disease early and manage them well in hospitals, as much as possible at outpatient hospitals, so that we don't waste the resources as inpatients for them, because it's also money for the patient who spends a whole day and a night in a hospital when that patient can get the service as an outpatient service. Then finally, we also have to think of the strokes and other rehabilitation needs, which is also not very advanced in our setups. Then this increasing injury burden. We have to think of things of addressing injuries, and we have to think of many ways. It has to get discussed, but through community empowerment and multi-sectoral approaches. Finally, we also have to think of the special interventions for elderly care. So, in summary, I think I'm just finishing within my time. I have tried to show to you a relationship between economic development and the health sector. And I have shown the changes that the sector has gone through, and to make all of us talk about and discuss so that we could address some of the challenges that we have for the future. Thank you very much.
Thank you, Dr. Kumari. Actually, you can speak for another 10 seconds if you want.